So I've been asked to talk about the peri-procedural pharma management. Can I go forward? Yeah. So I think what I'd like to do is just start off going through the protocol that was used in PROTECT-AF, because we shouldn't forget that this is still the only randomized study where any protocol has been assessed. So in PROTECT-AF, remember, all these patients were patients who could tolerate warfarin. And so the study was designed with that in mind. So all patients were on warfarin at the time of the procedure, and they carried on with warfarin until 45 days. And at 45 days, they had a TOE to confirm that there was no peri-device leak. And at that point, warfarin was stopped, and patients were converted onto aspirin and clopidogrel. And then at 6 months, they carried on with aspirin alone. So that's the only protocol that's been tested. Since then, of course, we've got alternatives to warfarin. And these alternative drugs have been tested in much larger randomized studies. So for patients who simply want an alternative to warfarin, we need to bear in mind that maybe some of the data that we've learned from PROTECT-AF may not be as relevant. But there's still a significant discontinuation rate in the new oral anticoagulants. And so there will be some patients that will still come through to our practice just on the basis of intolerance to current medication. So the data for the current status of left atrial occlusion tells us that most of our patients now that are going forward for closure devices are those patients with an anticoagulation risk and a CHAD score of more than 1. There are currently no randomized controlled studies of this group of patients with a high bleeding risk. There's also no formal guidelines for patient selection in this group of patients. And finally, there are no formal guidelines for peri-procedural drug therapy in this group of patients. And the PROTECT-AF regime, which was for a different group of patients, remains the only one tested by randomization. So in our practice, we find that the biggest group of patients we close are those with intracranial bleeds and GI bleeds. And then there are a significant group of patients with recurrent small bleeds, and then those patients who can't take various medications and have occupational hazards. And what we did was we start with the default assumption that we want to try and use the PROTECT-AF regime on these patients. And we discuss with either the neurologist or the gastroenterologist whether it's appropriate to do that. And if so, that's what we'll do. And with our sort of reasonably small experience, this seems to be safe to do. But of course, we'd like more data on that. And so what I'd like to do is discuss some of the data that is out there that we can maybe extrapolate to try and get an idea of what we should be doing. So first of all, let's review the data on why we should be using anticoagulation at all for the peri-procedural time. Now, we know that when you implant a appendage occlusion device, there's the prospect of forming thrombus over the device. So devices can be inherently thrombogenic. And that's not just on appendage closure devices. It also occurs on devices that are closed elsewhere. So in AST and PFO closure devices, we've seen thrombi formation as well. Interestingly, the presence of atrial fibrillation seems to increase the risk of thrombus formation on other devices, and this is probably because there's a more thrombogenic milieu in these patients anyway, in addition to the fact the appendage is a high-risk area. So if we go back to PROTECT-AF to try and understand what these device-related thrombi might mean, we can do that by looking at the ischemic strokes that happened. Now, in fact, one of the strokes that happens pre-procedure, 5 were intra-procedural, and it was assumed it was related to air emboli. So there were 9 post-procedure strokes that were left over. So these could be coming from a non-LAA source. They could be due to device-related thrombus or due to suboptimal device placement. And interestingly, in all the patients where an INR was available, it was subtherapeutic. So there were 15 of 389 patients who were seen to have a device-related thrombus on their TOEs, and of those, 2 had strokes. So that's a significant percentage of the patients who have a device-related thrombus that go on to have a stroke. So I think there's good evidence from here that seeing a device-related thrombus is a potentially high-risk feature that needs to be avoided and treated if seen. What other features might lead you to want to anticoagulate beyond the sort of normal standard timescale? Well, peri device leaks can be seen in quite a few patients, particularly with the Watchman device. And in this series, where they looked at small device leaks, less than 3 millimeters, there didn't seem to be much difference in terms of the stroke risk associated with it. And the stroke risk only seemed to go up after a device leak of 5 millimeters. But even then, if you looked at those patients who carried on warfarin in the context of a peri device leak, there was still a slightly lower event rate. But obviously this wasn't powered sufficiently to see whether this was something that we should adopt. We've also heard today a couple of times about this feature of gaps becoming present after what seemed like a complete closure at the beginning. And so one of the reasons why some of the echo specialists recommend that we do regular TOEs post-procedure are to look for these gaps that come later on, and whether to ask the question of we should be anticoagulating those patients for that timescale. So those are the possible reasons why you might continue anticoagulation in the perioperative process and then onwards after that as well. Now, clopidogrel is an interesting drug in this area because it's something that is used very commonly by structural doctors in terms of covering device closures, and not so much by electrophysiologists. And if we look at the data for clopidogrel, the largest series actually comes from the ASAP registry. So this was a post-CE marking Watchman series, where they took a non-randomized group of patients, 150 patients in total, who had a contraindication to warfarin, and they were given aspirin clopidogrel instead of warfarin as their peri-procedural drug regime. And they carried on the aspirin clopidogrel for 6 months. And in this group of patients, there was a stroke rate of 3 in the 176 patient years. There were 6 device-related thrombi seen, and 1 stroke in the device-related thrombi group. So again, a higher than expected percentage in those patients where device-related thrombus is seen. But overall, the stroke rate from ASAP was comparable to PROTECT AF. So it was suggested that aspirin clopidogrel was a reasonable alternative to warfarin in high-risk patients. But there was no data presented on recurrent bleeding rates in this group. For the ACP, there's still a paucity of data, and we all look forward to Apostolot-Silakis' manuscript coming out, because that will be the largest series of ACP data that's going to be available. But in the data that's in the literature at the moment, we see that in one series there were strokes peri-procedurally, and the 2 others there weren't any, and these were mostly patients that had aspirin clopidogrel for their peri-procedural implantation. But aspirin clopidogrel isn't a completely benign combination. In the active W study, if you look at the major bleeding rates, we see that the bleeding rate of aspirin and clopidogrel is actually higher than with warfarin. So if you're specifically using aspirin clopidogrel for a high-risk patient group, until we get a randomized study that tells us that it's actually safe to give aspirin clopidogrel in this group, I think you have to be wary. So potentially now, with all the new drugs available, we could come up with so many different combinations of peri-procedural antiplatelet or anticoagulant management. And actually there are reasons for justifying each one of them. And I think this really highlights, once again, the need for us to test one of these protocols in the high-risk bleeding population to see which one that we can give at least some more credibility to beyond personal anecdotal data, which is all we have at the moment. Now, in all of those combinations, I included aspirin as the last drug on which they carried on long term. And I just want to present some data on aspirin as well, which particularly affects us in the UK. I want to focus on patients who have GI bleeds. Now, when a patient has a GI bleed and is at risk of stroke from AF, if you restart their warfarin after the GI bleed is stopped, and compare them to those patients that stay off warfarin after the GI bleed has been controlled, we see that the patients without warfarin do significantly worse than the patients on warfarin in terms of cumulative survival free of major adverse events. So the recommendation from the gastroenterologist is if you have a GI bleed and the patient's got AF and there's a risk of stroke, you should restart their warfarin once the bleed has been controlled. But if we specifically look at rebleeding in these patient population, we see that the patients that do go on to oral anticoagulation do bleed more than those without. So potentially, there is this group of patients that we can help by providing device closures. But the problem is we use aspirin often as our long-term treatment, and most gastroenterologists don't like aspirin very much because if you look at the GI bleeders, the most common cause is peptic ulcer disease, and we see that aspirin is the most commonly used drug in many of these patients with GI bleeds. And if you look at rebleeding rates, and rebleeding is a significant problem for them because there's a high mortality rate associated with rebleeding, there's not much difference in the use of aspirin versus warfarin and NSAIDs in terms of rebleeding. So to offer a gastroenterologist a procedure which involves carrying on with aspirin long term is something that they're not terribly excited with in the UK, and their feeling is that most of the GI bleeds are related to either individual pathology, which won't be related to what drug you use, or it could be aspirin provoked. So we do have to test the possibility of putting these devices in and not having aspirin either peri-procedurally or long term. We've got some reassurance from another study, though. This was a study that compared aspirin against clopidogrel. Unfortunately, the aspirin plus esomeprazole group did very well for rebleeding rates compared to clopidogrel. So this is probably the only evidence that we can show the gastroenterologist to say that if we do go down the route of a closure device, by going on to aspirin and esomeprazole post-procedure, we may be able to reduce the risk of rebleeding in those patients. So in summary, the only protocol tested in a randomized fashion is the use of warfarin, followed by a TOE to confirm good closure, followed by aspirin clopidogrel, and then aspirin long term. And we need some trial assessments in some form or other to look at the high-risk groups. And if we do see surface thrombus and we use that as an endpoint, we need to appreciate that it does increase stroke risk, and that needs to be addressed. But to finish off, a plea, studies designed to test peri-procedural drugs in high-risk groups are desperately needed. Thanks very much.
Open for discussion? We can maybe open your talk for discussion or questions.
Papa, one question. The GI bleeding, this is what I understand. The gastroenterologists say the bleeding, the recurrence rate is the same either you go on warfarin or aspirin. So when we put in a device and put them on aspirin, we don't win anything. Is that the...
So in the UK, most of the gastroenterologists feel that the GI bleed isn't an issue. So that either the GI bleed needs to be controlled, and once it's controlled, they go back onto warfarin. And if they don't want to, I mean, it's rare for them not to put them back onto warfarin is their feeling. So most of the patients that we get referred to us after a GI bleed don't come from gastroenterologists. They come then from the family practitioner or the care of the elderly doctor, some other physician who's been looking after them, who's maybe then uncomfortable about carrying on anticoagulation. But the gastroenterologists themselves are not convinced by this technology at the moment.
So what would convince them? What would you need?
Well, I think certainly in the UK we could do the randomized study where if they have a GI bleed and that they're on warfarin, because they would be very comfortable with the idea of anticoagulating them as an alternative. The difficulty, I think, for us is to figure out whether we can power a study sufficiently to be able to get a meaningful result at the end of it. So then if we're planning it as a registry study, then again, it has to be designed appropriately that we're going to get good follow-up data.
In case of thrombus on the device, do you see something on different management? Is it only warfarin, or do we have experience with NOAC, or do we have published data so far?
I mean, we've used both NOACs and warfarin for the couple of occasions we've seen device-related thrombus, and they've cleared on both occasions.